Yeah, my name is Nabil Zafarov, one of the PGY4. This is a case given to me by Dr. Cohen. So, I have a 69-year-old patient is seeing well, and there's concern about their retina. Um, there's benign medical history. She's on sleeping pills. It's the only medication, and visual acuity is 20/20, IOP is 19 and 17. So, Grant, go ahead.
All right, so we got a fundus photo of the right eye. Media looks clear. The nerve looks flat with sharp borders. Vessels look fairly unremarkable. In the macula, there's are several like pale, looks like maybe subretinal lesions scattered throughout with sharp borders. Uh, and there's a few in the fovea as well.
Okay. Um, and if you go to the other eye,
The fundus photo left eye, clear media. Nerve again looks flattened, sharp borders. Vessels appear normal. And then again, similar looking lesions, mostly situated in the macula. They're pale, fluffy looking with sharp borders, and it looks like they're maybe a little bit more pronounced on this side.
okay. Okay.
So I believe this is an IR of the right eye, and there's maybe a sort of reticular pattern that's kind of throughout the macula, um, going like between all those lesions.
Right, and you can see like those you call it hyper uh yeah, lesions. You mentioned those in here.
Then left eye, very prominent hyperreflective macular lesions with sharp borders.
Yeah.
So this must be autofluorescence
Right.
of the right eye. Nothing really standing out. There might be a few hyperautofluorescent spots in the temp in like the macula. Nothing super prominent though. Then again in the left eye, more hyperautofluorescent lesions in the inferior macula.
Yeah, kind of just corresponding to those areas.
Here we have an OCT. I think it's the right eye. Uh, Media looks clear. Good foveal contour. Those lesions appear to be subretinal, um, maybe in the RPE with elevation of the ellipsoid zone above them.
I think this goes through.
So this is maybe a vertical cut. There's a lesion subfoveal um, um, in the RPE and the ellipsoid zone.
And these two are just blood vessels.
And then again, I think this is the left eye, so maybe some larger, more prominent lesions like we saw in the en face images with ellipsoid zone disruption.
Very good.
Then again, with a vertical cut, kind of a similar thing going on. You have a elevated RPE
I think this is still a
lesion.
horizontal cut. I think it's just
Yeah, it's horizontal. Yeah, talk louder. The horizontal cut. Good.
so here I'm just gonna go through it because it's a bunch of images in series, so you can kind of describe as you see it, but just more of those lesions that you're describing.
Yeah, and
Louder.
those are blood vessels in the inner retina, I think, that are a little hyperreflective. Yeah.
Yes, although that might be pigment migration over the spot. That hyperreflective spot's probably not a blood vessel.
Yeah, you're
Sometimes you get little pigment migration through the retina. Well,
How do I go back?
you got to click on the screen. There you go. Okay. That seems to be the theme. Okay, so go ahead.
Yeah.
Let's go back to the color. So what's that? It's kind of a funny looking eye. What's your differential for those spots?
I'm gonna go with drusen. Drusen, so like AMD, maybe some harder soft exudates. Maybe if we use our imagination, they could be like cotton wool spots or something related to Percher retinopathy.
See, one thing your imagination could stray to would be lymphoma. Lymphoma looks a fair amount like this. And then what else?
Like posterior placoid, like syphilis.
Yeah. Sorry, maybe it's just like little granulomas. Could be.
Yeah. So yeah, these are drusen. Do you have any classification or how would you diagnose it in terms of?
I think you need to talk about that.
Yeah. Okay.
Yeah. It's a nodules, and you got to talk louder because people can hear you on the internet.
Here. All right. So yeah, in terms of a differential diagnosis, kind of you can go with dry AMD. I think maybe central serous, like after central serous, you know, if they've had it in the past, and then pattern dystrophies. You always can think about with dry AMD, particular drusen, and probably even drug toxicity is a kind of a stretch, but it could be there. So yeah, we can talk about drusen today, kind of go into more detail on them. But what are drusen? They are the early hallmark of age-related macular degeneration. They're composed of lipids, carbohydrates, and proteins, and there's multiple ways that you can classify or characterize drusen. And really, there's these three main ones, and there's a fourth that I'll also go into today. And so one is by size, the boundary of the lesion, whether it's sharp or indistinct, and then what retinal layer that drusen is found in. And so here's a little chart I made, and you can see it. So there's three ways. One is the size. So there's small, intermediate, large, and then PED. So small is characterized by less than 63 micrometers, intermediate goes up to 125, and large is greater than 125. And the way you can kind of measure that while you're in the eye is by comparing it to the blood vessel as it crosses across the optic nerve or the lamina curvosa. You can, if that vessel measures about 125 micrometers, and so if the drusen is larger than that, then you can say it's a large drusen. And then in terms of the boundaries, you can characterize them either as hard, soft, or confluent. And so you kind of saw here there's a little bit of a mix of both. There was some hard and some soft drusen just based on their appearance in our case. And then the confluent ones you had where they kind of mesh together. And then finally you have the retinal layers that the drusen is located in. So you can have basal laminar, basal linear, and reticular pseudodrusen, and I'll go into that. And so these are what we'd call your hard drusen. You have these distinctive borders, and then you have your basal linear soft drusen that kind of have these indistinct borders. And here are just some more pictures of them, basically kind of with OCT photos as well. You can kind of see the hard and the soft drusen, kind of like what we had in our presentation. And then you have reticular pseudodrusen, which are considered to be more on the surface and usually located in this distribution like we just had in that case prior, right here supratemporally, that tend to be found. And so this is also on OCT. You can see reticular pseudodrusen. They're usually just multiple areas of granular hyperreflectivity. They're very shallow along the RPE or between the RPE and the photoreceptors, and tend to be supratemporal or in the superior macula. And then here's just an example of confluent drusen, which we just saw in our case, and you can see here they're just more kind of together and meshing in terms of the autofluorescence, and you can see on the OCT they're just very next to each other, kind of meshing. So these are the three classifications based on location or the depth of where the drusen are found. So the basal laminar drusen are found between the basement membrane of the RPE and the basement membrane or the lamina of the RPE cells, and they're kind of named hard drusen or given that hard drusen name. And the basal linear drusen are found within the fibers of the inner collagenous layer, aka soft drusen. This is a Brooks membrane, and so we'll go into that in a second. And then you have pseudodrusen, which are considered reticular drusen, and they're found on the apical surface of the RPE and the overlying photoreceptors just under the neurosensory retina. And so here's kind of a schematic of the layers, and these are all the layers of Brooks membrane. And so Brooks serves as kind of that barrier between the choroid and into the RPE and the retina. So, you know, we have the basement membrane of the RPE, we have the inner collagenous layer, we have the elastic layer, we have the outer collagenous, and the basement membrane of the choriocapillaris. And below that, you have here the choroid. And so basal laminar drusen in the schematic, you can see they're found in between the RPE cells and the basement membrane. And if they become extensive enough, they can detach at this area in what would be called the drusenoid PED. And then if you have here, basal linear drusen are considered to be in between kind of the inner collagenous, just in between the inner collagenous layers. So you can see there's two, so they're just found in that layer, and that can also, if they get extensive enough, can detach the inner aspect of Brooks membrane and produce also a PED. And then you have your pseudodrusen, which can come here, and there you can see they're above the RPE cells, and so out of Brooks membrane, and they're here kind of more near the surface, and they wouldn't really lead to PED. And so these are just kind of going into PEDs, like I was just saying, just to give you guys a little bit of background of the different types of PEDs. I think it's interesting, and sometimes you see in clinic to be able to distinguish them. And so here is just the development of it. So you have drusen, which as they can keep going now, you're kind of becoming a drusenoidish, and then a drusenoid PED. And then you can see.
Is this from the BCBS book?
Yeah.
That's like my grandmother wrote it.
And
This is the same patient, right?
There's a lot of retina specialists with a lot of time on their hands.
Yeah.
That's very beautiful slides.
They're great slides. The terminology is weird,
but yeah, so you can see here you're going to get some accumulation of vitelliform material over that area and associated pigmented changes. Which
did you make the slide with the drusen the last slide?
No, I got it.
Okay,
Yeah.
Cool slide.
And so it's just you can see the development there, which I thought was interesting. And then you have fibrovascular PEDs, and this kind of is different than what we're talking about, but you can see the difference in the way that it looks. You have kind of this medium reflective, and there's clefts in there. They're solid, and there's you know, reflective areas and not hyporeflective areas. And then you have serous PEDs, which are often smooth and dome-shaped, sharply demarcated, and pretty homogeneous inside, and they're pretty distinct in the way they look on the retina. So, and then we can go further into more drusen substructures. And so
The ophthalmologist just texted me a picture of you going to the lab. Now, the one with the pan lesion to check the SED rate, except on his case. Go ahead, sorry.
So drusen can be also classified upon being formed of cores, and those are basically called or localized carbohydrate moieties within the drusen, and they're composed of glycoproteins. Typically, they have been shown to have amyloid B and amyloid precursor proteins. They're immunopositive for immunoglobulins and complement and RPE pigment granules, and they're also immunoreactive for apolipoprotein E, which is part of the process in terms of how AMD happens when it's upregulated by Mueller glia cells. And so the fact that these cores and things are have these materials and these characteristics is very important, because that suggests that their formation is the result of immune-mediated RPE cell pathology, which is the main pathology in AMD, and they're biologically active sites in terms of atrophy progression and pathogenesis when it comes to dry age-related macular degeneration. And this is what kind of these new medications are trying to target. And these are just the photos of the different types of pores, and we're going to go into it. But you have the hyperreflective pores, which are these two. You have your medium reflective pores, which are the C and the D, and then you have your hyperreflective pores, and then which is E, and then you have these reticular pseudodrusen here, and then you have like these mixed pores, and we'll talk about these more. And so here's the paper that I was looking at. It classified them really as 4 types of cores. You have your low refractive core, which here is an example of, and you have then your high reflective cores, which here you can see here there's a little hyperreflective area within that drusen. And then you have your conical type of cores, where you can see the shape like a cone. And then you have your split reflective drusen, which you can see here. There's half of it is reflective, the other half of it is hyperreflective. And the reason that this is important is that these have been shown to kind of progress in the way that they're related to progression of disease or the risk of progression for disease and macular degeneration. So the paper that I was looking at, what it showed was, or the one that actually Dr. Cohen sent me, has
I forced them into this.
I'm just curious.
Sure, it was a funny paper. I don't think it was anybody super. I don't think it was one of the people you think like, because you think it would be
Saraf or something.
Yeah, Saraf or the guy in New York. I think that's yeah, or Spade or whatever.
Yeah.
No, I think this was just regular people.
Have you seen Rick Spade's rant live against the complement modulators? It's very good and kind of funny.
He's super smart. So, but I thought I thought it'd be nice to go dive into drusen. We talk about drusen all the time. I appreciate it.
Yeah, and I thought it was really interesting, and this is good because, or these classifications, at least in this paper, it said that there is kind of a stratification in terms of the risk of progression. Number one happens in terms of the conical debris with the highest risk. Then it goes to the high reflective cores, and then it goes to split, and then low reflective cores. So out of all of them, these low reflective cores have the lowest risk of, or I guess relatively less risk. So kind of the key points we just talked about is, in summary, you have drusen, which are a hallmark of dry age-related macular degeneration. And they can be classified on these 4 characteristics, one being size, boundaries, location, and the appearance of their cores on OCT. You have hard, soft, and reticular drusen in terms of their boundaries. You have basal laminar, basal linear drusen, and which are found within Brooks membrane and can lead to PEDs. And you have the progression to atrophy, which we went over for the core one. So that, like I just said, follows in this order of conical, followed by high reflective, followed by split, and then low refractive cores.
It's very nice.
Yeah.
Thank you.